Hi everyone, happy Tuesday. Welcome to the last episode of Series 8 of Probably Nothing. I don't know how we've managed to get to the end of another series. Time flies when you're having fun, doesn't it? My name is Karen. As I say in most episodes, to try and make you laugh, please don't let that put you off. I promise I'm a nice Karen and I want to be your friend. I'm not a Karen. I'm a very proud ambassador for the Eve Appeal, the UK's gynae cancer charity. And Probably Nothing is our weekly live chat show where I interview guests about different gynae health, gynae cancer topics. We started Probably Nothing in June 2020 because our Ask Eve service, a free information service where you can ask nurses any type of gynae health query, was getting a lot of questions from people saying, sorry to bother you, it's probably nothing, but, and most of the time, the probably nothing is probably nothing. It's something less serious than gynae cancer. But for about 60 people every day in the UK, that probably nothing is something. 60 people are diagnosed every day in the UK with a gynae cancer. And we wanted to create an informative and easy to understand, accessible space where we can ask your questions to the experts. So this series, Series 8, has been focused around womb cancer, particularly womb cancer and postmenopausal symptoms in the Black and Asian communities, because some research was done in 2018 and showed that women from Black and Asian communities are more likely to be diagnosed with a stage 4 womb cancer than a stage 1. And with cancer, there is no stage 5. So we've had different guests each week. First guest was Dr Aziza, a GP, and we spoke about womb cancer symptoms and getting yourself to the GP for that initial appointment. Then in week 2, I spoke to the wonderful Dr Ayushi Pandya, an obs and gynae doctor, about what happens when people are referred to her to investigate potential womb cancer symptoms further. And then last week, I spoke to the lovely Jackie about her lived experience with womb cancer and what it means in terms of being a Black woman and trying to help her community in getting to the doctor if they have any concerns. And the last episode of the series, which is today, is a GP drop-in session. We've done these for a few of the final episodes of Probably Nothing before to end other series, and we love it. It's kind of a casual way of asking. I've got a whole list of questions that you've sent in for our wonderful GP guest, Anne. I'll bring in Dr Anne now. And if you're watching, you've seen this before, you know the drill. I'm going to maybe let Anne speak in a second, and then we're just going to plough through as many of these questions as we can in just under half an hour. So Anne, hello, who are you if people don't know you?
Hi, Karen. Thanks for asking me on this session again. It's always great to join you on this. You're such a star with doing these. And the term probably nothing, I don't know how many times I've heard that. So I agree with Karen. If you've got something to talk about, go and ask, because if it matters to you, then it matters. So please don't feel that it's probably nothing. So I'm Anne. I'm a GP. I'm based in the middle of Bradford. If you know Bradford, it's a fantastic place, very deprived, very diverse population where I work in inner city Bradford. So this is a great topic. I've got a real passion for women's health and just encouraging people to actually go and talk about their issues. And, I'm here to answer as many Karen's questions, and she's going to be kind to me, she says. So I'm going to ask
her. And just to comment before we start on the questions, I love that note that we're starting on of if it matters to you as the patient, it matters to the doctor. I think that is so important for people to hear from a GP. So thank you for saying that, because we say it all the time, but to have someone, the GP that people might go and see, whoever their version of you is, I think that's really important. So thank you. Okay, let's get into it. Okay, here are the questions. I have symptoms of ovarian cancer, but my GP says I have IBS. I don't know what to do.
Great question. I don't know how old you are. That's probably the first thing to know. IBS is very common in younger women. Ovarian cancer is rare. It's not unheard of, but it's rare in younger women. IBS, particularly presenting for the first time. So IBS is irritable bowel syndrome. It gives women a feel of fullness. It can do alternating diarrhea and constipation. And it can often make you eat and then you go off to the toilet. So you can imagine when you're young, doing exams, you often get IBS type symptoms. And I certainly did when I was trying to get my way through med school. But IBS presenting for the first time in women over 50 is rare. So if you're over 50 or postmenopausal, then IBS for the first time, it's a diagnosis that really we tend not to make first line. So if you are postmenopausal or say 40 and above, then you should go, if you've still got the symptoms, go back to your GP. Now, again, I don't know if they've done a blood test. The blood test we tend to do is something called a CA125. It's not a great blood test. It's the one we've got at the moment. New markers are coming, which are going to be much more exciting, much more specific. But at the moment, we've got CA125. Even if you've had a CA125, which is normal, and you've got the same symptoms, then revisit it. So if you come to me as a GP after 3 months, same symptoms, certainly if you are more mature, then I would be doing your blood test again. And again, if it is normal, then if the symptoms continue, then I might refer you for a scan or even ask somebody else to see you. So it might be probably nothing, but it might not be probably nothing. So go back, feel empowered. That's what NICE says. And NICE are our guideline experts. So go, and that is what NICE guidance says.
Go back. And what if somebody is 30 and saying the same thing?
So 30, it's much more likely to be irritable bowel syndrome. So it's much more likely, on balance, on the whole, ovarian cancer is mainly of older women, but there are some younger conditions, particularly if it runs in your family. There's lots of guidance. You've got guidance on Eve Appeal website, so have a look at some of those guides. Look at the symptom diaries. Keep a symptom diary. But if you've still got IBS symptoms and they're bothering you, then you need some care for your IBS as well. So yeah, go back.
That's so true, isn't it? Just because something isn't a gynae cancer and isn't that serious, it doesn't mean that we should still put up with it. Like, oh, it's just IBS, it's not ovarian cancer, that's fine. Or like, oh, it's just endometriosis, it's not womb cancer. It doesn't mean we have to put up with it just because it's not something that's got the cancer word smacked on it.
Yeah, exactly.
Okay. I've been having this strange, very light bleeding starting about 1 week before my period. What could be causing it and what should I do?
So again, it's not straightforward because it depends on your age and depends on your risk factors. If you are young, I'm presuming you're not taking hormones, you're not taking contraception or HRT. If you are younger and you are getting a bit of bleeding before the period and then going into the period, then it's just likely to be that your hormones are a little bit, they're not maintaining the lining of the uterus quite well enough. So one of the options is to take hormones. And you could take the pill, or you could use hormones for a few months just to regulate it and to check it's okay. If, however, you are older, so 40, 45 and above, or if you're diabetic, or if you're overweight, or if you have got a condition called polycystic ovary syndrome, which is when your periods are more spread out, but that irregular bleeding is happening, then go to your GP because they might want to do some investigations. So when I'm sitting in the GP surgery, every person is different. So I have to think of a personalized plan. I have to do an individualized risk assessment because different things matter to different women depending on their personal risks. But again, if you haven't got an answer, keep a diary so you can go to your GP, go back to them. And it might be the nurse in your practice actually who's doing your women's health. So look on your website, see which one says they do the women's health, make an appointment with that person. You might have to wait, but that's okay. Go to that person with your diary and say, look, this is happening. Please, can you explain? Do I need investigations, or can you just explain what might be happening?
And if it wasn't, this is my own question adding on to it, but if it's not bothering the person, they just want to check it's not serious, but say it wasn't anything serious and it was just this slight hormonal fluctuation that you mentioned at the beginning, is that okay? Can they live with that? Is that sort of just like, okay, one of those things, they get a bit of brown discharge a few days before, oh well.
Yep. It depends. If it leads into the period, then it's one thing. If you get that brown discharge a few days before the period, then you're clean and then you have your period, that's different. If it runs into the period, then usually it's just a bit of the lining of the womb is starting to break down a little bit earlier and slower. The brownness is just a slow bleed, and then you go into your period. So yeah, it may be that you live with it if that's your choice, but you can't make that choice unless you know, do you? You've got to have the information.
Of course. Okay, this one doesn't say specifically what it was for, but let's see. My GP referred me urgently to a gynecologist. The hospital have said the consultant said it isn't urgent, and my appointment will be in about 12 months. My GP said there's nothing they can do. Why not? So why has it gone from GP to consultant no? That's quite worrying, isn't it?
It is.
For the person, for the patient.
Exactly. Gynae have got a big problem at the moment because gynae waiting lists are the ones that were probably most compromised with COVID.
Why?
They got less time in theatres. They got gynecologists. They had to focus on obstetrics, and then the others had to go and fill up the rest of the hospital needs. And even with catch-up gynae lists, they're sort of the last to get through theatres. We can all shout about it, we can scream about it, but it's
I was going to say the politics of this, of gynae getting neglected again, is a whole other episode, isn't it?
Exactly. But gynae waiting times have been one of the most compromised. So so there are very long waiting. I've never seen waiting lists like there are in gynae in my many years of doing general practice. Your GP might not. We have certain fast track guidance. So on NICE again, there's a cancer one. Anyone can look on NICE, which is the National Institute of Clinical Excellence. There's one on cancer, and on that it lists which are the cancer ones. So they're the clear red flag ones. So they are the ones where nobody can argue.
Yeah.
But there are some others where your GP might think it's higher risk, and it might be. But your GP might also think this is higher risk. But actually, when you look at the evidence and you look at the risk profile by someone who's more experienced, they might say, well, look, that is not high risk. It's concerning for that patient, but it's not high risk. And actually, I've got all these other higher risk patients to see. So, and they are right, as GPs, we're full of patients. We're so busy at the moment with anything, but we're also seeing endless patients who are coming and saying, I haven't got my appointment yet. The problem's still ongoing. I haven't got my appointment yet. What can you do about it? What can you do about it? And actually, we are pretty stuck. Sometimes we will ring. You could go up to A&E, but you'd waste your time because they'd just say you've got a referral, so it's a problem.
Yeah, I appreciate that honesty, that there's not always kind of a great, clear, positive answer to it. Like there's certain things where there's no argument. You are going to get your referral quickly. Exactly. But for a lot of people, they're going to be waiting. And I think the mental health side of it, of waiting, is sometimes as bad, if not worse, than the physical symptoms sometimes somebody might experience, right? Like this person is probably feeling worse because of the mental toil that this is taking, waiting and worrying.
Exactly. And that, well, my GP is worried, therefore, obviously I should be worried. And that just adds to that.
Of course,
but,
of course it does.
The GP probably was worried. But the gynecologist is the expert, and they are having to triage and manage their workflow.
I had my last period 2 years ago, and I've now had some spotting. What should I do?
Well, definitely, that's
red flag. That's a red flag. Yes.
That's a dry. More than 1 year after your last period, that is a red flag. That is, I need to be seen. Now, if you're up to date with your smears, then that is more likely to be coming from the womb or even the ovaries. If you are not up with your smears, then your GP will need to have a look and check that it's not the cervix. But if you're up to date with your smears and they're negative and you never had a problem, it's more likely to be coming from higher up. And that is, your GP needs to fast track you. And a fast track is a 2-week appointment. And you will go to the hospital. And if you're not up to date with your smears and there's something going on with your cervix, you'll go to colposcopy, which is where they'll look at your cervix with a magnifying system. If it is you're up to date with your smears and they don't think it's coming from your cervix, then you will go into a fast track bleeding clinic. And what you will do there is you will have a scan. The scan will look at your ovaries, and it will also measure the thickness of the lining of the womb. If the lining of the womb is very thin, they will tell you it is due to dryness, and there's discharge you. If the lining of the womb is thick, then you will need a telescope test, the hysteroscopy, where they put the telescope inside the womb and have a look and see if there's something going on. It might be a polyp, which is like a little skin tag. It might be a little fibroid. It might be an area that is pre-cancer or even cancer. So don't ignore it.
So it doesn't mean it's necessarily cancer, but it's just something to be taken that bit more urgently than if they were 35 and having some unusual bleeding, for example.
Exactly. 10% of postmenopausal bleeding will be from a cancer. So, 1 in 10. So 9 in 10 aren't.
Can you take speaking of atrophy, can you take vaginal estrogen for vaginal pain and vaginal atrophy if you've previously had atypical complex hyperplasia? First of all, what is atypical hyperplasia? And then can they take the estrogen if they've had that?
So the way the lining of the womb works is you've got normal. Then you've got what you call hyperplasia, which is thickening, sort of very early pre-cancer stuff, which probably doesn't always, very little of it will progress to cancer, but it just doesn't look normal. And then you get atypical hyperplasia, complex atypical hyperplasia, which may progress on to getting womb cancer. So normally if you've got complex atypical hyperplasia, you will have had a hysterectomy. If you've had a hysterectomy, then vaginal, you've lost the problem. Your womb's gone, so fine. So vaginal estrogens are fine. If occasionally they don't do surgery and they will put an intrauterine system, a hormone coil inside to try and reverse the problem. If the problem is reversed with that and you've still got that intrauterine system in, then you probably could get away with vaginal estrogens. But there are also lubricants and moisturizers that you can also use. Some you can buy over the counter, some you can get on prescription, but there are alternatives if you want to avoid vaginal estrogens, and they work well. Some you use all the time, and that means you just feel more comfortable. Some you also use during sex, and you can double up, so you can use a moisturizer and a lube during sex.
If someone's using the vaginal estrogen, how long does it last for, like each time? Is it something they would need to use daily, or just maybe a few hours before they wanted to have sex, or an examination if it's for a medical reason? Like, how does that work?
So vaginal estrogen plumps up the vagina. Postmenopausally, our estrogen levels drop. The vaginal lining thins down, as does the lining of the womb, as does the bladder and the muscles and sort of everything pelvic-wise. Everything drops southwards. But what you do with vaginal estrogens, and some are little tablets, some are tiny little things on a little plunger, some are like little bullets you can push in, some are creams, there's even one that's a ring. What that does is it plumps up the vagina again. It puts estrogen back to where you need it to be. Now, most of them you will use nightly for either 2 weeks or 3 weeks. And then once you've got it back into that part of you functioning better again, then you go on to twice weekly, or the ring just stays there for three months. And we tend to give, as GPs, we tend to give out 3 months supply. But that's fine. You'll feel great within a couple of weeks. Everything happy. You're back to painless sex and just feeling better. And it helps with your bladder control as well. The problem is that we give it for 3 months and then we sort of stop it. And then the problem goes back to where you were again. So don't be frightened about using vaginal estrogens longer term, because actually that's what you need.
Thank you. I have very intense and heavy, painful periods. I don't have endometriosis, but I do have small fibroids. Will I ever get a permanent solution?
The problem with small fibroids are thickening of the muscles of the womb. So the womb is about fist shaped and sits right down in your pelvis there. And it's got, most of it is made from muscle, because it has to go from this size to this size for pregnancy and back down again. And fibroids are little swellings, we call them benign, so they're non-cancerous. They're little swellings inside the womb. And it depends where they are as to whether it causes a problem. Most women, by the time they get to menopause, will have some.
Really?
African women will have more, and more likely to have bigger ones than Caucasian women. if you've got little ones, your womb's just a little bit bigger. It doesn't usually cause a problem. If you've got one or two very big ones, they can cause pressure symptoms and they need removing. And it may be you need a hysterectomy if you've got some of those bigger ones. If you've got little ones and they are sort of bulging inside the womb, they might make your periods heavier. So you might, because they sort of distort the lining of the womb, stretch it if you want. And so if they're very little, you can use something like hormones. The intrauterine system, the hormone coil, works very well for that if they're little ones. Taking any hormonal contraception will help with them. So again, it depends where they are. It depends what size they are. And it depends if they are actually what is causing the bleeding. Because all those little ones that just sit in the muscle there, they're probably not doing anything. It's just about the ones that are inside or the very big ones that are causing pressure symptoms. But, if you've got them, go back and ask. Don't tolerate the heavy periods. Just because you've been told, oh, you haven't got this, doesn't mean you don't need a solution.
Right. During perimenopause, if bleeding between periods has been identified as being caused by the hormonal fluctuations of perimenopause, is there a way to know what to look out for that might be abnormal bleeding that requires more investigation? I've heard this question so many times. How do you know when your periods are changing, because you're going through the change, whether this is my periods just changing because, my ovaries are shutting up shop, or because I've got a potential red flag symptom of a gynae cancer? How on earth are you supposed to know?
Great question. It's a seriously great question, and one that challenges, people like me and the gynecologist. So it depends if you've actually had an answer. So if you've got, menopause, basically you start to get, what you're happy with at menopause is less frequent periods, and then they'll stop. So that's fine. But a lot of women around the time of the perimenopause will get totally erratic bleeding. And then we have to think, am I worried or not? If it's sort of relatively scheduled but heavier, on the whole, that's probably okay. But if you've got intermenstrual bleeding, so bleeding between the periods, then you do need to talk to someone about it, because they will need to decide, is this your hormones, or is this a polyp? Is this a fibroid? Is this a cancer or a precancer? So you can't, even 45 and above, you need to start thinking about, should I get this investigated? And there are other risk factors. So if you are obese, and that's a BMI of over 30, if you are diabetic, if you've had a history of polycystic ovary syndrome, if you're using the breast cancer drug tamoxifen, if you've got on hypertensive medicines, those things should make you think, I need, get investigations earlier. So again, I'll be looking at you and I'll be thinking, am I going to give you a trial of hormones? Do I need to do some investigations?
My vulva is itchy and sore. What's causing this?
Okay. Another great question. So premenopausally, it's usually thrush. So thrush infection, we probably all had thrush infection.
Do you see a lot of people with itchy vulvas, or is it kind of they'll only come to you if it's gotten super bad? Because I know I've had thrush, who hasn't? And I just sort of sort myself out. And I know if it persisted, I would go to the doctor, but I haven't had to. So do you think by the time typically people come to you with an itchy vulva, have they often tried thrush stuff and it hasn't worked, or have they not heard of thrush before and you're telling them?
Both. But premenopausal women are much more likely to get thrush than postmenopausal women.
Okay.
So postmenopausal women, they will get thrush if they are diabetic, if they are immunosuppressed, so on, fancy rheumatology drugs or HIV drugs or something like that, or if they've recently taken antibiotics. But apart from that, generally postmenopausal women don't get thrush.
Okay.
Postmenopausal women are much more likely to get a problem called lichen sclerosis, which is a bit like eczema of the vulva and even around the anus, or it might even get psoriasis. So the first question I will ask somebody postmenopausal is, do you have any other skin problems? You look on the elbows, you look in the flexures, hands, about dermatitis. And then, it's simple stuff to start with, soap avoidance, lots of moisturizer, and sometimes it will settle down. But if it's persistent, you need to have a look, because there's a condition called lichen sclerosis, and worse than that, there are sometimes you can get, again, pre-cancer changes. So you can get vulval cancer. Vulval cancer is rare, but if there is one bit that is persistently itchy and whatever you've put on it, it doesn't settle, please go quickly, because that might be something that needs looking at.
Thank you. Okay, 2 more questions. We've got a few minutes, 2 more questions. Let's do them. Okay. I was HPV positive last year, so went for a colposcopy. I had 2 biopsies and they were determined to be low grade, and I was referred for a smear in 12 months. I'm HPV positive and have some cell changes, so have to have another colposcopy. I'm scared this will keep happening until something gets worse. Can I have these low grade cells removed?
So the answer is yes. So normally you carry on being monitored, and what they're waiting for is for you to get an immunity yourself to HPV. And hopefully after 3 or 4 years, you get your HPV negative smear, and then you get back onto normal recall. But if it persists, you can ask them at the hospital, at the colposcopy clinic, say, is it worth me having a procedure, the treatment procedure, which is where they inject, numb that bit of the cervix. Now, a little wire loop, they just burn out the middle bit, which is causing the problem. And there are some women who choose to have that. I wouldn't rush to have it, but if you've been 2, 3, 4 years and you're still fed up of it, then you can ask, and they will talk to you about the risks and benefits of having that done.
Because the fact that it's staying low grade means it hasn't developed, but obviously,
Exactly.
Like we spoke about, kind of the mental health, like stress and worry and anxiety over something more than nothing still being there, even though it's not something. It's between nothing and something, isn't it? And
exactly.
So yeah, okay. Okay, last question. I have a family history of Lynch syndrome. How do I get tested to see if I have the gene?
It's a great question. They've all been great questions. So on target ovarian cancer, I don't think you've got it on Eve Appeal. Maybe you have, but there are some tools you can get on some of the charities. It might be Ovarian Cancer Action, but there's a tool where you can put in the questions and it will tell you about your personal risk depending on your family.
We've got a Lynch guide, but I don't think we have an interactive tool as such. But yes, fine.
Yeah, but if you've got, so have a look at the Lynch guide to start with. But if you've got a strong family history, now some people say, oh, I've got a family history, it was great Aunt Flo, that's not family history, it's immediate family. So it's usually mum, sisters, dad, brother. So if you've got a strong family history, you go to your GP, and we've all got genetic services available. So what we'll often do is ask for advice from the genetic service. And then the genetic service might, depending where you are, they might say, oh, do this blood test, or send them up to me and we'll talk to them about it. But, if you're going to have that sort of test done, you've got to be pretty informed, because once you're identifying you've got the gene yourself, then you've got to make decisions about how you manage that.
It's a lot of knowledge to sit with, isn't it? If you know you have got this significantly increased risk.
It is. And some people say, absolutely fine. I know I've got that risk, right? I'll have my breasts taken off. I'll have my ovaries removed. I'll go for that, but that's a very informed discussion to have. It's not a simple test to have. It's not just like, shall I just, find out what my blood group is, or, find out whether I'm anemic or not. It's, you need to think it through. But again, if you want to talk to it, go and ask your GP. But be informed, get as much information as you can about it first, so that you're probably even ahead of the game.
Anne, we've finished bang on. I know you've got another commitment. I don't know how you do it all, but thank you so much for another great drop-in session. I love ending our Probably Nothing series with these sessions. I think they're really, really helpful, and I'd love just firing questions at you and you just knock them out the park every time. Thank you so much.
Great. Well, Karen, you do a great job, as do the team who put these videos on for you. So thanks for asking me.
Thank you, Anne. See you later. Bye-bye. Oh, love Anne. I think that it's really, really helpful and hopefully kind of enjoyable, and puts lots of kind of people's minds at ease to see, a GP there answering your questions. They're real questions that came in for Anne. And yeah, I really enjoyed talking to her. We love doing these sessions with her to end the series of Probably Nothing. And as Anne said, and as you know, I hope I always thank them. Maybe I don't. Maybe I should thank them more. But a big thank you to Disruptive, who do all of this streaming of Probably Nothing completely for free for us. You know, if you ever need people for an event, they might not do it for free for you. I think you have to pay them. But we are very, very grateful to everything they do for us. If you're watching this live, thanks so much for joining in. If you're watching this on catch up, thanks for taking the time to catch up. I hope you've enjoyed this episode and the other episodes of Series 8 of Probably Nothing. We will be back soon with Series 9. We're going to get to at least Series 10, aren't we? Let's face it. Thank you again. Stay safe. And if you ever have any questions, you can contact our Ask Eve service, which is nurse@eveappeal.org.uk. And you can ask any type of gynae cancer question. Nothing is too big or small. Thanks very much and take care.